Now, a lot of people do think that the valgus perspective to the OA is sort of a mirror image of what you do on the varus side, whether you do osteotomy or whether you do uni or whether you do, but it's totally, completely a wrong concept. It's not a mirror image at all. It's completely, it brings along a completely different set of variables, and it is completely, one must not fall into the trap of thinking that you're just doing a mirror image of what you do for the varus. The second point about valgus is that it's rather an uncommon deformity. So patients who don't have, now I think we see about every 10 to 15 varus we see only one valgus. So if some unit doesn't have a high volume of knees that you see, you probably will not be see any valgus knees. Therefore, you take an occasional one on, and that's the advantage of a group practice like that. So we all do knee work, but some are specialized in one area or the other. And therefore, we are able to give a comprehensive service. And what is the real bottom line is what is best for the patient, not what you are good at, but what is best for the patient. Yeah. So osteotomies on the knee, we were doing a lot I remember doing as early as 2001, we were all doing, but it's a lot of hit and miss. And therefore, we sort of gave up over a period because some did very well, and some we found that they just was very poor results, just a hit and miss. But now it's become a really a very trusted procedure where you can give guaranteed results. Absolutely great procedure. And that I think today in 2020 there must not be any knee unit which says I don't do any osteotomies. I don't think it is acceptable anymore. And we sort of do lots and lots of osteotomies in our unit. My slide is not progressing. Okay. So some of you may know this is Bob Booth. Now, Bob Booth is one of the most high volume knee arthroplasty surgeons in the world. He does about 20-25 every day, and I'm sure you must have seen his videos how to maximize OR efficiency. It's absolutely brilliant to watch him perform. And I think he must have done more than 50,000 knees. And last year he made this statement, which many of you may be surprised. He said I still haven't understood the valgus knee. This is somebody who does done more than 50,000 knees and does 20-25 TKRs and unis a day. For him to make a statement like that he hasn't understood the valgus knee, that's a message in there itself by none other than Bob Booth, who's one of the primary designers of the Persona knee. So, as I said, you should never make the mistake of thinking that the valgus is a mirror image of the varus. A lot of other things going on. The diaphysis deformity of the femur is more. Unlike tibia vara, where you get the varus deformity, the femur remodeling is very, very common, almost the rule in any genu valgum that you come across. So therefore, you got to take that into account. Now, unlike the medial side where you have only the superficial MCL to contend with, it's a sort of a rather uniplanar or biplanar structure for you to handle very easily. But here you have different structures, and they all involved differentially in different patients. So you cannot say the LCL is the contracture of postal capsule. It will depend on the patient and the deformity, and therefore it brings in a whole level of complexity to it. Now, rotational deformity, especially acceleration of the femur, very common as a part of the valgus, plethora of deformity, and one has to be extremely careful to deal with that. Now, as Suri mentioned, laxity is a much more common, and many patients will come to you more with laxity than pain when you're dealing with the OA on the lateral side, and you must be extremely careful to deal with the laxity. So I show you this this patient of mine. Valgus deformity, did a TKR, pretty good looking x-rays that we used to those days, small, but then he found that you see how she has failed in progressive laxity. Although the TKR was okay, I had not done a full length scanogram at that point, and I got a lot of things wrong. This was about 10 years ago, and we got it wrong, and you can see how it has failed in progressive laxity. Yeah. So valgus is a much more of a beast than a varus. So don't make the mistake of thinking it is just a mirror image that you're dealing with here. Now, uni is very popular now, and now unit we do lots and lots of unis. We have done so many hundreds and hundreds of unis, but we are on the medial side, but we still haven't done a single one on the lateral side. As again, a message by itself that the lateral compartment is a much more complex compartment than the medial compartment. So, especially if we do the Oxford, we consider the medial compartment to be a ball and socket joint, so it's very easy. Whereas lateral compartment is a really beast, and so don't make the mistake of thinking that it's a mirror image of the mid side. Now, this is the slide that I use only to the juniors ask which do a H2O or a uni. You can see all the different things. When we have a bone changes, maybe uni is better, and you have extraocular deformity and osteotomy is better, etc. Higher active level and osteotomy is better. Lower active level, fat obese patient probably uni is better. This is all well known. But the point I'm trying to make is, although this applies very much to the medial side, on the lateral side, since we don't do a uni, we don't have the option of 99% of centers. We don't have an option of a lateral uni, a reliable lateral uni. So the pendulum most definitely swings towards the osteotomy side. Most definitely, no question about that. So because we don't have the uni, we have a relatively early AMOA or single compartment disease, the pendulum swings definitely towards the osteotomy side. So with that intro, I will pass on the stage to Dr. Clement, who will go through the basics of it. Dr. Clement, thanks. I'll just stop sharing.